Welcome to session 8 of the 2025 Implementation Science Reading course. To take the long view, you have now journeyed through the basics of implementation science and all aspects of the implementation science logic model. And last session, we had a really riveting panel about community engagement. And as promised, this week, we are doing a panel on quality improvement and implementation science, because we know a good portion of folks work out in the community outside of Northwestern. And for many of you, your partners are the health system itself. So we have brought together an all-star panel of 4 leaders within Northwestern's Feinberg School of Medicine and Northwestern Medicine. I'm not sure if they'll be doing formal intros, but I just wanted to briefly note the unique vantage points that these leaders bring that we will be benefiting from for the next 30 to 60 minutes. But basically, all 4 are absolute leaders in their fields, and they bring very complementary perspectives. Lisa Hirschhorn approaches this work with a global health lens and is an expert in considering ongoing process and quality improvements in low and middle income countries. Pat Franklin comes to this discussion as a global leader in learning health systems work and assessing quality from the patient perspective using patient-reported outcomes. Renad Baitis is an implementation scientist extraordinaire and comes to this work really thinking about the nexus of implementation science and quality improvement and how the 2 fields can elevate each other. And Cindy Barnard is a global leader in quality improvement work and recently semi-retired. We are lucky that we can't get rid of her and want to keep her forever. But she was vice president of quality for Northwestern Memorial Healthcare and semi-retired, but still continues to generously share her expertise as a researcher and health educator within Northwestern. So they'll be speaking to us about their shared expertise. And I believe Lisa Hirschhorn is going to kick us off. And then we will have opportunities for engagement with this expert panel. All right, Lisa, take it away.
I'm going to start with an overview. And so really, we're going to try to say what do you need to know about QI as an implementation scientist? What do you need to know about implementation science to strengthen QI? How can these disciplines work together to make the work better and sustained? And then some really exciting examples that we'll share. And then Renad will be moderating the panel discussion. I will say that we decided to not really focus so much on improvement science, an area that there's some debate about and certainly a lot of stuff written, and certainly the 2 papers that you read. But we decided to be more pragmatic and therefore really are focusing on QI, but happy to answer questions about improvement science when we get to the open session. Next slide. So before we start, we really wanted to just kind of give a little refresher on what is quality, because sometimes people sort of get a little confused. And the recognition is quality is a priority for everybody. Everyone, nobody I know comes to work and says, today I'd like to be mediocre. Today I'd like to actually deliver bad care. But we know that it's often a challenge for how people to actually not only have it as a priority, but implement. And so the definition is delivering what the patient or the consumer, depending on what your terminology, needs and wants. And really how we define it can be very sensitive to the setting, as well as which of the domains that we actually think about. So, for example, if you look at this is from the Institute of Medicine, already widely used globally, which says quality actually has a number of different components. And if we think about that from an implementation science perspective, each one of these may have different strategies, may have different barriers or facilitators, but we're going to, for the purpose of this, sort of lump them all together as quality. So to think about this measurement of quality really is important to have a framework and some common definitions of metrics. So if I'm saying, gee, is Cindy actually providing, good quality care? Does she and I have the same definition? And very importantly, when we think about people-centeredness or patient-centeredness is the somewhat outdated terminology used here, is does it actually meet what the patient expects in terms of quality? So I think the question is sort of which of these overlap with implementation outcomes that we might already be measuring, and where might there be some gaps? And I'd like to, if we have time, just to take one quick minute and have people put into the chat. Do any of these resonate with outcomes that you may be measuring or thinking about measuring? And where do you see some implementation outcomes that don't really track to this, or that these don't track to implementation outcomes? Maybe while we're waiting, I can ask some of my panelists, does any of them stick out to you as something that perhaps we need to think a little bit more? I know that there's been a whole session, I think, on the use of equity as frameworks. And so equitable, I think, is one of the areas that, that implementation science has really been focused on. But are there any of the others that sort of stand out to you?
I'd like to comment. I agree that I think that more recently implementation science has been doing a better job at centering equitable implementation, although there's still much work to be done. One that really sticks out to me is the timeliness one. So I had the opportunity to participate as part of a panel at the most recent Academy Health NIH Dissemination and Implementation Conference. And there's this whole discussion with regard to how speed and timeliness fits into how we think about implementation. And that's an area I think where there's a lot of opportunity for this group and Northwestern to kind of think about and put our spin on it, because there's what I had the chance to kind of moderate a debate in terms of slow versus fast versus just right. It was really interesting, and I think we could do a lot more good thinking in that space.
Great. And Howard Kim wrote very good that efficiency is one outcome that strikes me as difficult to define and measure. I think a lot of people often will put that as sort of with cost, but I would agree with you that efficiency, and especially balancing efficiency and people-centeredness and equity, is often very difficult. Often the most efficient way of doing things is not necessarily the most equitable. People-centeredness relates to acceptability and adoption, absolutely. I think in terms of particularly acceptability, but I'd say that we probably fall a little bit short, for example, as I'm looking at directly at Pat, our integration of PROs, patient-reported outcomes, into some of the implementation science frameworks that we use. And yes, Corey, notions of safety, this was done in a much more traditional way in terms of medical errors, which is indeed an area of focus, but indeed who actually thinks about safety and, exactly as you say, trauma-informed approaches. So really, really helpful. Okay, I'm going to go on to the next one, so we have lots of time at the end for questions. So what is quality improvement? We sort of felt also it was important just to define this. And the definition, or one of the definitions, is the incremental implementation and adoption of both the what and the how in specific practice settings. And so the idea is, remember, this is really focusing on local knowledge and local change. And quality improvement teams, so QI is always a team-based effort, it's not an individual one, but they both implement best practices to improve the outcomes, but also, very importantly, reduce variation in existing best practices. Because if we remember, quality improvement actually comes from industry. So if you want your Toyota to actually work, you want it to always be exactly the same. You don't actually want variability in your Toyota when it comes off of the line. And it should include structured rapid cycle adaptations of implementation strategies, usually within a single context. And this has actually expanded over the last couple of years to be not just what we call the micro level, influencing behavior change, but also thinking about some of the changes in system. But the key thing is that it does require change, because as Batalin said, that every system is perfectly designed to get the outcome that it gets. And so if you're not getting the right outcome, you're going to need to change the system. Next slide. So when we think about this, the most classic sort of framework and model in QI is called the model for improvement. It's what are we trying to accomplish? So what's the gap? How will we know that a change is improvement? What is the measure that you're actually going to do? And what change can we make that will result in the improvement? And that often goes into this sort of cycle of what they call Plan, Do, Study, Act, or PDSA, because we all love our acronyms as well. Sort of planning for the change, doing the change, seeing if the change is working, and then acting. If it's working great, you might go to sustainability. If it's not working so well, you might adapt it. And this is meant to be done really at a rapid cycle. This is not a year-by-year type event, but something that's sort of by weeks or at most by months. Next slide. So if we think about, how do we map this and how do we bring this to improvement science? If we think about the pre-implementation or the exploration and preparation, that's sort of the planning part of this. The implementation is the doing, the studying, the check. And then again, for sustainment, we should think about if we're going to adopt it, but if not, do we adapt it or we abandon it? Something that I know de-implementation is an area that really needs to be done. And there's some other, things, for example, DMAC, which is very similar, define, measure, analyze, improve, and control. And there's other approaches, but we've decided to not try to go through everything with QI, but you can begin to see that there's some areas where we use different language, but we're actually doing some of the same things and where there could be some very important cross-learning. Next slide. So when we think about this, and this is adapted from work that Hendricks has done, is the idea that we're going from, the efficacy trial to the effectiveness trials to implementation practice and implementation research. Next slide. So traditional role of quality improvement has been, again, this idea about how do we improve implementation practice? So again, how do we do this for local knowledge and local change? Did I change my clinic or my health center? Next. But I think we're going to argue that if you can integrate implementation research or implementation science methods into quality improvement, you can not just have local change, but can actually create generalizable knowledge. And going from the idea of this exploration and preparation to actually making change, implementation, and very importantly, sustainment, because that's often a challenge with a lot of quality improvement where I've come back 2 years later and nobody has any recollection that we did anything. Next slide. So when we think about this concept of overlapping practices, again, implementation practice is the knowledge translation. How do we get it to people who need it? It's the process of putting evidence into practice and the deliberate use of strategies. So again, as we said, QI is the systematic and cyclical data-guided activity. So there are data in QI. It's just a little bit different. We don't focus on p-values, but we focus on really near term. Sometimes we say, what can we do by next Tuesday? Immediate practice improvements, and usually focusing on a single site or system setting. So if we think about that, where is that sweet spot in the middle where the Venn diagrams will overlap, where implementation science can help you to design and study the use of these strategies, and how does this produce generalizable knowledge? So when we see change, for example, at Northwestern Medicine, how can my old area of practice, Dimmock Community Health Center or Brigham Women's Hospital, learn from that? How can we create that type of generalizable knowledge? And there's already some strategies that are used in QI, like learning collaboratives, but I think by bringing in implementation science, we can make this stronger. Next. So again, this is where we sort of find where there's overlap inpatient from patients and or clinicians or administrators or community, context-specific implementation determinants or drivers. We call that sometimes a fishbone diagram, a root cause analysis in QI. We call it, formative work or contextual inquiry in implementation science. And then measuring the implementation, the service, the patient outcomes. Again, you can really see where you might be actually having this type of really area of synergy. Next slide. Next. So this is one of my favorite things that I use from Renad, which is the roadmap. And the idea is that really when we think about sort of where does implementation science lives, it's really sort of going into the yellow and the green, the green where we might do hybrid studies or we might do pure implementation science studies. But when we think about quality improvement again, we might be using mixed methods to understand the context. Why is it that the nurse is not actually taking the temperature? Talking to her, observing, seeing, is there actually a thermometer in place? If not, that's a problem. Designing the implementation strategies, again, remember about the plan, and then testing them. That's the do, the plan, that's the do, study and act part of QI, but it's also part and parcel of implementation studies. Next slide. And again, we all are trying to do the same thing, that there's a no-do gap, and whether it's in quality improvement, there's sometimes a no-do gap, but actually we also need to think about what I call it the do quality gap, which is people are doing it, but they're doing it incorrectly. And going back to that question about outcomes, fidelity, technical quality, maybe there's some area for synergy there as well. Next. So if we think about things about parallel and different, so we both areas love their acronyms and love their jargon. And so we just try to do a little bit of this idea. So when we talk about understanding barriers, again, with QI, we do root cause analysis, fishbone, 5 whys. Fishbone has the same idea of these different kind of domains that, for example, CFR does, implementation science and contextual analysis, CFR, socioecological model, and many more. Designing and choosing the solutions, QI, you might do a priority matrix. You might take it from a change package, which is a series of best bets or good ideas that other people have. We do driver diagrams, which actually are very much like mechanism mapping, and PDSA cycles. In implementation science, we might do implementation strategy, mechanism mapping, the CFR ERIC, tool that people use, Testing change, QI, typically we look at process measurement. We don't usually look at sort of longer term outcomes. Implementation science obviously is both implementation outcomes, but then also sort of what's the best study design for it. QI intrinsic in there is rapid cycle changes. Implementation science, you can do it before starting or integrated into the study design and using things like FrameIS. And the definition of success is one that is hotly debated, but in QI, it's change is seen. And you can sort of debate, would love to hear from Cindy when we talk about it. It's like, what's good enough evidence? And in implementation science, it's often statistical significance. Next slide. So one work that I've done, and this is work that I've done with Rohit Ramaswamy, is sort of, well, how can we actually think about integrating implementation science approaches into continuous quality improvement? So we took the model for improvement, right? Remember that? What are we trying to accomplish? What's the problem? How do we know a change is improvement? And what change can we make that will result in the improvement, going to the Plan, Do, Study, Act? But the idea is that when you're starting to actually dive into what change should you make that will result in improvement, that's a perfect opportunity for implementation questions in the role of implementation science. So what are the implementation outcomes that are critical to implementing the change? So if, for example, and this is from work that I did in India, we have a nurse who's not actually taking the temperature, we actually need to see adoption. Is she not willing to do it? Does she think it's not appropriate? Is it not feasible because there isn't a thermometer? What are the factors that are going to impede achievement of these outcomes? So you've already decided what the changes that you want to have happen. And therefore, what are the implementation strategies that are the most appropriate to address these? And these can then feed back into it, but it's a more rigorous way of taking a look at this, and done in a longer time frame can actually, again, result in generalizable knowledge. And we'll give some sort of examples of that in our case studies. Next slide. So how can implementation science improve quality improvement and vice versa? Because we should really recognize this rapidity. And I have to say, if anybody who was there who watched that debate, Renat, I thought it was one of the most entertaining but very insightful things about going fast versus going slow versus sort of staying the course. Next slide. So I'm just going to take one example of this, which is that even the implementation research logic model can help with this. And so when you map it to QI, next slide. When we think about it, the implementation strategies, sort of when we, with implementation science, we think about it as a deliberate application. And again, remember the predetermined thing. Next slide. Remember, all of these need to be context dependent, and that's true both in QI as well as implementation science. Next slide. So when we think about this, applying it to quality improvement, we think about the determinants, again, the root cause analysis. You might do that. You might look at the key drivers. What do we know? Why the nurse doesn't take her temperature? Is it using components of COMBI, for example, or other? We work a lot with the WHO health system building blocks. The strategies, again, are the things that you do to address the gaps. So that might be a Plan, Do, Study, Act cycles. It could be a learning collaborative. Those are all sort of strategies that are part of quality improvement. Again, the thing could either be the actual thing, but it could also be the processes of what's needed to actually have the thing. So for example, if we want to treat pregnant women in delivery who might have sepsis, we need to take their temperature. And so we might not actually look all the way down the line. Are there women who are being saved? Are they actually getting sepsis treatment? We might start with that first process step, which is taking the temperature. The implementation mechanisms of why do we think this is going to happen, the changes we expect to see. And these are something that driver diagrams are actually often very helpful to say, like, what are the gaps and why do we want to do them? Again, in quality improvement, the measurement is often more process focused. And then we look at quality outcomes as well as sustainment. Next slide. So now I'm going to turn this over to case study 1, who is Cindy.
Thank you so much. I'm going to give a double-barreled case study with a couple comments about why I'm so enthusiastic about bringing implementation science to quality improvement. So if we go to the next slide, a couple of years ago, Northwestern Medicine was fortunate enough to successfully compete for a PCORI contract. Different from what you might know about PCORI, this was not about comparative effectiveness research. Instead, this was about implementation. PCORI picked a bunch of health systems that they thought were really good at doing implementation and charged them with creating a network that would show others how to do it well. And they wanted to do this in a systematic and controlled way. So it's a two-part project. Our first contract was for what they called capacity building. And we looked at our quality improvement work at Northwestern Medicine, which has been my corner of the world for the last 30 years. And we did a very hard-headed look in the mirror to think about all the ways quality improvement fails, all the ways it doesn't live up to our expectations, all the ways it could be better. Again, this is a health system recognized as one of the nation's best, and yet we, people who've worked within the system, know every wart and gap. We did a great brainstorming exercise with help from Renat and Pat and Kelly Scott and others. And then we said, how can implementation science fill those gaps? It turns out other people have thought about this problem, but at this moment, there is not a published, validated, tested model that actually brings all these pieces together for optimal performance of both quality and implementation science. We have now completed that contract. We developed the integrated toolkit, and we're now going on to the second phase of our contract, which is to apply this tool in a series of clinical projects. One of them has been funded by PCORI already, and that is intensive lifestyle interventions for weight management in primary care. It's a really cool, exciting project that primary care folks have been begging for a long time, and the toolkit will now be tested there. In addition, the health system has agreed to test these concepts and methods in other high priority quality improvement projects. So when we come back to this class next year, we will have the opportunity to report on where the toolkit actually improved performance and where we have done further refinement and improvement. And if you go to the next slide, this is essentially how we have built the tool. We don't use PDSA at Northwestern, and that's a good discussion for another day as to why. We think the DMAIC tool is better: define, measure, analyze, improve, and control. And it is an excellent framework. However, as I say, it can often let us down. And I would just editorialize that one of the ways DMAIC lets us down is the more we rely on brainstorming without discipline, without structured ways to think about what is it that the customer or patient needs, what are some proven intervention strategies, et cetera. The more we rely on brainstorming, the more we're limited, frankly, by our own experience. One of the things I think implementation science really brings to the table, and a lot of you have done QI, is it brings us a more disciplined way to think about some of these steps. So what we did, as you can see here, with huge help from Renat's team and Sarah Becker's team, was to identify which elements of implementation science can most contribute rigor and discipline to what is already a decent but not perfect quality improvement system. If you go to the next page, then what we're moving on to now, as I mentioned, is from the toolkit to the implementation. You can see a little bit about the PCORI network of health systems implementation networks. And I will only conclude by saying, when we met with them last week and they complimented us on finishing the capacity building work and the toolkit, they mentioned that most of these high performing implementation health systems have mentioned the same need we did. They all want this kind of a toolkit. It is going, I am convinced it is going to meet an important national need for really high performing quality improvement in future. And a huge thank you to all of you for helping us build this out.
Hi, so I'll take it from here. I'm Pat Franklin, and it was a pleasure to work with Cindy and the NM quality leaders, as well as CDIS and the MSS faculty on that toolkit. And I agree with you, Cindy, that I think there's a big opportunity for the complementarity there. So next slide. I'm going to give you a use case from my own examples. And I wanted to just start by saying I trained in quality. I am a health services and patient-centered outcomes researcher, but my formal change in training was quality, from the Deming-Durand Institute and what was going on decades ago at the Institute for Healthcare Improvement. And I have been pleasantly surprised at the overlap, but the rigor and refinements that are very detailed through the implementation science methods. And I think that it's not just complementary, it's in many ways augmenting some of the foundations that we've known in the quality world. So as we already talked about the process improvement, we talk about reducing variation as well as improving outcomes. So using the use case of implementing patient-reported outcome measures in care, you might say, well, PROs have been around for a decade. True. They're in the EHR, true, but right now the average use rate in the use case that I'm going to explain today among arthritis patients who are electing joint replacement surgery, the average reporting rates are around 30% at the time of surgery and even lower after surgery. So the question would be, how would we use these for care if we don't address the implementation of PROs in a more systematic way? The second thing to know for context is Medicare, starting in 2027, will offer a financial incentive to use PROs. So that was the context for this research. This research was funded by PCORI under their cost effectiveness design program called Improving Health Systems. But we won't talk about the design. We're just going to talk about PRO use and how both the concepts of quality and implementation science informed our design. So I led this study that was funded as a multi-system PRO implementation project. We were comparing it to other options, defining, and with the opportunity, because it was multi-system, to define the similarities and differences that needed to be actually adapted across the health systems that participated, and to provide an additional level of evaluation and assessment. So the PRO implementation, when we sat down with our patient advisors as well as clinician advisors, we said, you know what, we're going to think about process change in the patient side of things, meaning the patient's interaction with the healthcare system, as well as the health system's change. So we actually thought about it, the ILM, as working both in the patient perspective and the health system perspective. While both quality and implementation science hold patient engagement as foundational, this was actually saying, what are the systems changes in the patient's life that we would need to address if we want PROs to be uniformly completed before they arrive in the clinic? And in parallel, what would the changes be in the health system? And then design the study. So do all exceed the value of this added detail, which is completing the PRO? Do all have a cultural environment where patient-centered care and the use of patient-reported outcomes matter? Those were some of the questions on our mind. Next slide. So I'm going to lead you from top left to the right here. It's just saying, first we had these two components. We have what's the patient doing at home? And they may be technology enabled, but we understood there was a suboptimal engagement. The office staff are fully engaged with the people in front of them, right? The people here today. They're very busy and overwhelmed. But what this is doing is thinking about people who are coming in next week because we want these PROs completed. And that's in our mind, it was a system shift in both sides. So we were thinking about patient and staff reminders and a pre-visit completion of PROs to minimize the workflow disruptions that would be possible in the clinic. We also knew the endpoint was in the middle, the exam room. We want the PRO and a report available to the patient and the clinician at the time of the visit. And we defined the intervention as having an IT system consistent with PRO collection, the generation of the report, and the availability optimally pre-visit so that it will not slow the office visit. We left the opportunity, as you would in implementation science, to adapt the staff training embedded into each of the sites. And that's based on my education and quality, that there are always local and, resource and people and educational constraints that you want to tend to. We wanted to certainly adapt to honor the leadership support in the 12 systems, and the workflows were going to be varied across sites. So if you just hit the next slide and the next slide, it's just showing you that the outcome of these process changes were generating the pro and embedding it in a report, which we could talk about at another time. Next slide. So the study does, this is without, you know, getting into the study design, but just the measurement process. The intervention is the PRO scores, not just collected, but used, because they're embedded in a report that was co-designed by the patient and clinician. The second was an attention to the multi-level strategies that were needed to optimize leadership engagement at the high level, including the IT being interoperable, the clinical care team understanding the why and the how, and being prepared to use the data. And then I put in purple there, I guess it's a purple, this bi-weekly contact. That was actually our mechanism for the adaptation, watching what's happening with staffing, turnover, flow, and as you will hear, COVID in the middle of the study, so that we became really nimble at a traditional plan, do, study, you know, cycle of adapting the how and the why embedded in. But the intervention stayed the same. And then last, the engagement in the multimodal outreach to support patients, because they were a equal and critical component of this work. So the measurement was driven by the REAIM model, you know, just the traditional measures of overall and by the site among the 12 sites, the feasibility of the pro collection, the rate of patients having pros available at the time of their visit, getting at that timeliness factor here. Then in the adoption side, we were attentive to subgroups of patients, and that diverse patients and settings would have comparable rates of use of the PROs in the report, fidelity in the discussion, and then acceptability. And why I put blue in those two is that we used a research approach to augment the evaluation through qualitative interviews and post-visit interviews with patients and clinicians to get a better sense of that, the integration and the usefulness of the report and the pros. And then last, well, if you collect the pros, you have the measures of function and pain, which are critical to arthritis care. But we also added in blue the assessment of decision quality, you know, the process of making a decision for care that patients reported to us. So I put this measurement scheme to show that it's very implementation science. It's got a quality engine embedded in it. So I don't think of it as different. I thought of it as trying to pull upon the best of what we were learning from each discipline, and working in this multi-center role. But we knew we also had lessons learned about what was different across systems in their use, their adaptations, and the value. Next slide. And this is my last slide, just to say, in maintenance, we're going to talk about is that pro completion before and during COVID actually gave us a natural experiment of the sustainability of some of these methods. So what we wanted you to see, I wanted you to see here is just some baseline data, which is on the collection rate and the method of the process. But we also did a lot of work on the impact. But you can see that about a third of patients just did, with the right engagement from their doctor, saying you'll complete this because we'll review it at your visit, and it's important to our assessment. And a third when we reminded them from the office staff, not us, the study team, the office staff, you know, this is important, we'll be using it. People completed these pros before they arrived, but a third didn't. They needed support in the office. And we could talk about what we've learning about that group. During COVID, we amped up our reminders, and we did get this to about 76% of patients completed the pros so that the report could be available at the visit. And that's obviously different from the routine care today. And there are a lot of lessons learned there about once people saw that data were used and it was a repeat visit, et cetera, how that adaptation happened. And a quarter of patients were best served by support in the office despite all of this process. The best part that was useful to me to understand, because we wanted to get beyond collection to use, is that 70% of patients who were surveyed among the first 5,700 told us they reviewed the report and used it with their doctor. And then the qualitative work elucidated how it was beneficial and how it was used. So this is just one example of both variation and improving the adaptation of something that is adopting a new test, for the lack of a better word, a measure of pain and function that is going to have both policy implications, but has been a challenge to the clinical community to uniformly integrate into their care. So thank you. I'll move to the next.
Great. So I'm going to go through this very, very quickly, but just to sort of show that this is not just what happens here in the US, but also globally. Next slide. So we did this to actually use implementation science to understand and improve quality improvement. And so the NEST 360 is led by investigators out of Rice University, and then has 5 countries that it's working in now, and is supported by a number of different institutions, including Northwestern University. So the challenge is that early neonatal mortality in sub-Saharan Africa is about 80.3 per 1,000 live births, which is much, much higher than 27. And we have a whole bunch of evidence-based interventions that can help with respiratory support, keeping babies warm, phototherapy, kangaroo mother care, preventing and managing infection. But there's huge gaps in availability, use, and quality. And this is definitely a gnarly, complex problem that required multi-level, multidisciplinary solutions. So to do this, it's an international alliance of now 17 organizations, 13 in Africa, including Northwestern, and it's united to end preventable newborn deaths in African hospitals. Next slide. So what was the quality improvement gap? So in the first years, there was a focus on improving the ward and the facility quality improvement capacity. And this was done with a lot of energy and a lot of interest, but there was little change that was happening in quality and coverage. And the question was why? And really, when we went and sort of did this root cause analysis, we sort of found there was a lack of data availability and use. So this whole thing, if you think the M in DMAC, the S in study for PDSA, quality improvement methods were not being well implemented. So this had to do with fidelity of the strategy as well as adoption. And there was very limited integration of clinical quality in QI. So somebody would come in and say, you're not putting the baby onto respiratory support correctly, and here's what you need to do. So that was individual, but the quality improvement about why they weren't doing it, there wasn't enough tubing, there was power outages, et cetera, was not integrated. And so to really address this, we developed a new dashboard called Nested, which actually very rapidly takes process measures and allows people at the individual facility, at the country level, at the program level, see what's actually happening. We revamped the capacity building and coaching quality improvement. We integrated it with clinical coaching and education, and we actually saw remarkable change. It was really exciting. A huge number of these sites are now meeting their targets that are needed to reduce mortality. Next slide. So we want to see how this is done, and this is work that's led by Kylie Dougherty, and it's already accepted for publication at BMJ Quality and Safety. And we said, well, what happens if you actually put an implementation science lens? Does this help you understand the story of what actually happened? So this is a retrospective evaluation using implementation research logic model. These are actually some of the domains from the small and sick newborn WHO quality of care. So again, we adapted this to be able to do that. You can see there are quite a few things that are little down arrows in red, which meant gaps. These were all the different implementation strategies that were actually happening. And some of these were actually in the implementation factors were facilitators because of other work that was happening in NEST 360. So Cara Palamontagne, for example, was leading some very cool work about making sure it was the right equipment. There were other people who were making sure there were biomedical engineers who were actually maintaining the right equipment to get rid of what we call the equipment graveyard. We were able to understand the mechanisms and really map it quantitatively to some of the implementation outcomes, but also looking at change of the facility, the clinical, and ultimately level for that. And then ultimately sort of nationally and globally, what we wanted to do was to increase quality improvement and data use activities and scaling it to new NEST 360 facilities. This is currently national scale in Malawi, but it's going to scale in Tanzania, Kenya, Nigeria, and Ethiopia as well. So we really sort of looked about this as a good way of doing this, and I'm going to turn this over now to Renad.
Awesome.
Oh, I'm sorry. There's just a little bit more. We also look positive outliers. We're developing change packages. No, go to the next slide. Sorry. Mapping barriers to strategies. And we actually have this thing, which is like what we call evidence-based strategies, which should always be done. An example of this is fix the broken window. You don't need to do PDSA cycles. You don't need to do QI. If you have a broken window and you're taking care of small and sick newborns, just fix the window. So we have that's our new thing, is fix the broken window. Sorry, over to you, Renette.
Thank you. Well, I'm actually going to ask Sarah, do you mind if you just take the slides off? Because this is going to be the interactive part, and it'd be great to have us kind of all represented as part of the panel. If you don't mind unprojecting. Yes, fantastic. So I really deeply enjoyed listening to our panelists share their expertise in the ways in which quality improvement and implementation science should be married and are stronger together. I had this thought, in the mixed methods implementation science literature, there's a lot of description for the studies that we do as being like big quan followed sequentially by little qual, or big qual followed. I was almost thinking in the examples that we got, I could almost adapt that typology to think about like which came first, the QIRS, what's more emphasized. But I think the takeaway, so it's just like a side thought, but the takeaway is that they're stronger together. And one thing that I think that they undoubtedly deeply have in common is this laser focus on using the scientific method and data to help us improve the quality of care. And I think that, implementation science, as Cindy noted, really allows us to bring some of this rigor and systematic approach to thinking about how to do the work, and the production of generalizable knowledge, which I think is really important because hospitals across the country are thinking about how to improve various quality of care matters that are the same. So we need to be thinking about how we produce that generalizable knowledge. And these are really just new tools to add to the toolkit. So I see that Sarah had put a great point in the chat, which is that we should think about if we want to do small groups or if we want to go to the moderated questions that we had planned, and also solicit questions from our audience. So I will give it back to the CEDIS crew to execute that poll before we either move forward with the questions, which I can moderate, or break into small groups.
So I put in the chat, I think we're going to forego that poll just for sake of time, because we ran decently long on the content. So I think just keep going.
Okay, I can do that. Thank you, Sarah. All right, so I am going to ask now that our audience send any questions that they have in the chat. I also have some questions prepared, and I also know that folks sent them ahead of time. So thank you to Jessica, Eric, and JJ who sent questions in advance. That's always incredibly helpful. And so I'm actually going to start with the questions that were sent in advance, since they're really good ones. And I'm going to start with Eric Robinson's question. And they noted quality improvement methods training have become well incorporated into medical education and ACGME standards. So all residents or most residents have to do a QI project as part of their clinical training. What would it look like for implementation science to make similar inroads, and how would we measure the impact?
Yeah, that's a really interesting question. I would love, that is a very timely question. I think it's great that it's acknowledged that you need to lead change. We need to be attentive to measuring the current state and improvement opportunities in your own practice. So having those quality skills seems very foundational to me. And I would hope that you would be drawing on generalizable methods and generalizable learning that you could share. And that would, to me, be at least an immediate opportunity, Renat, for you bringing implementation science in so that people see their lessons learned in the context of how they can disseminate and we reduce that variation in care.
So Pat, would you think about that as bringing implementation science into those quality improvement methods and trainings that already exist?
Exactly. I can't see why we wouldn't bring the best of both worlds. Like even using the toolkit that Cindy described, we could definitely put those in. And I think that's a great question. I'm happy to participate in a conversation about that.
Lisa, it looks like
yeah,
you have
no, absolutely. I'm all for it. So first of all, I was delighted when QI got brought into training for clinicians. I think it's really a making sure that the entire team is getting this as well. So nursing students would love to see that. pharmacy students. So we'd love to see that sort of scaling out. But we also have this concept, what we call embedded implementations research, where we actually are really training in a lighter touch sort of frontline providers to understand how they could do, we call it peer pragmatic embedded implementation research. So I think integrating it in would be fantastic, but also recognizing that a lot of times QI is very clinically focused. And so figuring out how do we actually give people the time and the space to think a little bit more broadly, and particularly as teams, and perhaps it could be that groups of students are doing this sort of QI implementation science. But I think understanding how to integrate it into the training that's already happening, I think is always a fantastic idea, and creating a generation of embedded implementation researchers.
Yeah, so I'm hearing integration, embedding, also honoring the contributions that the field of implementation science brings. I'm going to ask a hard question. I'm going a little rogue. What do you think is stopping us from that integration? Why aren't more places across the country adopting that approach?
You know, I could start by commenting that the vast majority of people in quality improvement don't know what implementation science is, may not even know it exists. Those in academic medical centers for sure. But beyond that 100 or so academic medical centers, I think you'd have to look pretty hard to find even an awareness. And so what happens is people who want to do good quality improvement focus on trying to make it better over and over with the tools they have available, focus on sustainment, which is a chronic problem in quality improvement, trying to hammer away at the same problems with the same toolkit. And I am convinced that if we really want to lift quality to the next level, we need new tools. And this is the kind of resource we need. However, if you follow the rest of quality improvement, you know, this really came about in healthcare in the late 80s, early 90s is when it all started. And these methods were imported from industry into healthcare with the unique adaptation we needed. And it took a while before some of the leading, both academic and non-academic centers got the literature out there for other places to learn and implement. And I think we're in exactly the same place. We need to go to the next level with better methods, better measures. And this is, I think, the pathway to do it.
And I just want to add, though, I think also, and again, similar to Pat, you know, my original training and was both in infection control and QI, and you know, a lot of my initial research was sort of much more about, you know, improving quality as opposed to implementation science. And so it's been interesting to come at it from both ways, which is I think both fields sometimes get stuck in their jargon. And if you've ever been on a panel where you have a quality improvement champion and an implementation science champion, it's not the same sort of like integration agreement that we're having on this panel. But often there's a lot of dismissiveness that happens between, you know, QI people think implementation science work too slowly, implementation science people think that QI people are loosey-goosey in their evidence. So I think some of it is also getting the two fields, similar to I think what we've done here, to really sit down and figure out how to do it, what's the minimum amount, really sort of creating the kind of guidebook that says, look, you're doing some of the similar things, you're just doing them a little bit differently. And by incorporating them, we can actually make this stronger and make the changes more generalizable to accelerate improvement and make them more sustainable.
And I know, Corey, you had your hand raised, but let's talk about the speed issue, because I think there's a perception that often when we insert this kind of additional layer of rigor and kind of scientific inquiry, that we slow things down. And also, I would say that from my perspective, implementation science spends more emphasis on community engagement in the kind of pre-process, which also slows things down, but is important for implementation to go well. So can we talk a little bit? I'd love to hear your thoughts on the speed issue and whether implementation science slows things down and how we might address that, given that if we are to truly integrate, our pace probably needs to match, at least get closer to the QI speed.
You know, from the practical health system perspective, there is not patience to wait. Once a problem's identified, a charter is set up, a team is put together, there is great urgency. And some of that is because there's something going wrong clinically. And there's a sense that you can't afford to be leisurely in fixing a safety problem or a quality problem. And parallel, as long as you want to develop generalizable knowledge, which has been one of the core aims of implementation science, of necessity, it will be slower because you've got a lot more preparation, a lot more representativeness to think about, a lot more, I mean, there's IRB and so on and so forth. So I think there's good reason for why the timelines have been different. And I think there's good reason to be optimistic that we can do better. If QI incorporates elements of implementation science as a matter of routine, then a lot of the basics will be in place. If implementation science anticipates areas where we know there are quality gaps in the industry and develops proposals to tackle those common serious problems, I think we can converge, but it will take intentional planning and work.
I agree with you, Cindy. You know, what I was going to add is in multi-center work is what I've noticed is that's a slow process, right? And really, actually, some of that adaptation that I was describing was to get around the lack of consensus building that would be necessary and might be inappropriate, right? So an optimal implementation study might have said, these are the mechanisms and it's going to be uniform, but we didn't go as deep into the day-to-day workflow for reasons of both, time and adaptability and truth to the local needs of these people. So I think that for me, the goal I can see, like, so you've done a nice job, Cindy, of saying, how will I integrate these tools within my health system? But the next step would be, if we have generalizable population data across systems, could we be scaling our lessons learned across systems in a not slow way to really raise the whole bar of where we can go. So I don't think it's simple, or it would be done, but I do think it's aspirational, and there's reason to believe we could, get closer.
And I think that there's also missed opportunities. So, in QI, we talk about common cause versus special cause. Special cause is like one thing that happens in a place and man, you gotta fix it. But there's often things that are actually happening across other things. So there's things that people are doing individually and responding quickly, maternal mortality reports, near miss reports, things like that, which are then drive change. But if we had a way of actually capturing that and understanding this near miss happened across 25 hospitals in in Illinois, that would be a perfect opportunity for implementation science, because then you have to understand, is it that it's a perfect storm, but it's a different storm in each one of the hospitals? Highly unlikely. Or are there actually things for which there need to be strategies to make change? And I think some of the things like ILPQC, the Illinois Perinatal Quality Collaborative, is a really good example where they've been able to do both QI, but we have actually some research grants to actually study the implementation of broader strategies where there has been a common cause or a common challenge. So I think the answer is that there has to be better collaboration, better sort of dissemination of information. And I'm always fascinated by these near misses and some of these mortality reviews that I think, again, are underutilized because they may be viewed as unique, but often they're not.
Thank you all. And I'm trying to do the chat and follow the conversation. So this is really exciting. I think what we're hearing is that embedding and integration is the future forward, and a close hand-in-hand partnership between quality and implementation science. One thing I might leave this group to think about is, how do we get there? And are there opportunities to convene more improvement folks from different systems and implementation scientists to really come up with an action plan around how we move forward? It's wonderful that we now have this toolkit, and I think the PCORI HSII will be a great test bed in which to see how this plays out. But I think we probably also need some action steps, and I like to end presentations on everyone thinking for themselves how they might move this forward in their own way. So encourage you to think about ways that we can continue to solidify our partnership between these two fields. Is there anything else our panelists would like to add as parting words before we wrap up?
Thank you. We need you.
And I want to also thank the organizers for inviting us, because I'm hoping this is just the first step in a ongoing conversation, how we can do this both within Northwestern medicine, but then also beyond. So hoping for this is just the start.
And
Thank you so much.
Oh, I'm sorry. I was just going to say, I saw Corey mention learning health systems in this chart, and I see that as not another layer of tools or techniques, but just a philosophy of how we could bring, if we're bringing both of these resources together, how we, it's a continuous learning to improve outcomes. So thank you.
Fabulous. I want to thank our very busy panelists for taking the time to share their wisdom with us and helping us to push forward our thinking at this really exciting juncture of implementation science, research, implementation practice, and quality improvement. We will meet again, I believe, in 2 weeks for session 9, which is all about sustainment. Really excited to get together and to see you all in 2 weeks. And thank you all so much for this rich conversation.